Thank you for inviting me to give this talk on maximizing PrEP use and retention at the national level. I will address how to maximize PrEP use and retention at the national level by addressing each of the points in this slide. We need to build a case for PrEP based on public health and health economics. We need to understand figures on HIV, new infection, and on PrEP impact. We need to understand, and this is very important, I want to stress, the context where we want to maximize PrEP use and retention, and build alliances that are strategic to our setting. And this involves involving alliances with politicians, with policymakers, those working in the HIV field, but also in general public health, involve clinical societies, patients associations and NGOs, academia and industry, and involve all these possible actors in decision-making and accountability. Regarding the first point, building a case for PrEP based on public health principles and on health economics, it is important to build a case of PrEP need within the 2030 Sustained Development Goals. You're aware of the 17 Sustained Development Goals expected by 2030 and how Goal 3 involves good health and well-being, and within these targets we have ending AIDS by 2030. And we have a number of targets like 0 new infections, that's a 90% reduction in the new infections, together with 0 deaths and 0 discrimination. By 2030, by 2020, we had a number of targets which involved the reduction of new HIV infections to fewer than 500,000. And in 2016, a political declaration on ending AIDS by UNAIDS recommended the initiation of 3 million people on PrEP by 2020. Where are we now? Well, if we look at figures in the Global PrEP Tracker, we can see that in the third quarter of 2020, just under 800,000 people were initiated on PrEP. So well below, the 3 million people for 2020 recommended by UNAIDS, still a long way to go in increasing the number of PrEP initiators. If we move to the second item, understanding figures from other countries on HIV new infections, and how PrEP has impacted either in a positive way or in a less positive way. I do not have time in this 15 minutes talk to go into the HIV epidemiology, but it is important that you go into that when you try to develop your case for PrEP in your setting. I will go through the trends in the numbers of PrEP initiators in different settings to draw conclusions. So when we look at the overall number of PrEP initiators worldwide, we can see in the darkest blue the countries with the highest absolute numbers of PrEP initiators. We see United States of America with just over 200,000 people initiated on PrEP. And we also see very high numbers in South Africa with close to 90,000 people, and Kenya with over 72,000 people. But if we look at trends over time in the United States and South Africa, we see very different trends. And we can see that while in South Africa numbers are increasing, in the United States the curve has blunted from 2018 onwards, and it's it is important to understand why these numbers are not increasing. Have we reached all people in need of PrEP, or aren't we reaching a vulnerable group or a more difficult group to access PrEP? This is very important that each of us looks at our context to understand why. When we look at numbers in Europe, things are slightly different in magnitude, and I would like to focus on two countries. France, which is the first country that incorporated PrEP funding to public reimbursement, to full reimbursement of PrEP provision to PrEP users, and the earliest one, and the current number of PrEP users in France is 23,500, and the UK with just over 18,000 people on PrEP. And when we look at trends over time, we see that in both countries numbers are increasing, which is reassuring. When we look at two other countries, and I will focus on Spain, my country, which has introduced reimbursement of PrEP in the public system in the national healthcare only a year ago, we see that our numbers are increasing, although the magnitude, as you can see, is low, and we've got just under 2,500 people on PrEP for a large population. When we compare these figures with the Netherlands, a country with a smaller amount of, with a smaller population, we see how the number of people in PrEP, which also started rising only in 2019 when it was publicly funded, it has increased very rapidly with 4,500 people in PrEP. So very different contexts which are important to understand. And this takes me to the third point on the importance of understanding context. And the first context, the first issue that is important to address are the barriers to PrEP use and retention, which in many occasions have universal aspects that are common to all settings, but in others are context specific. I want to highlight this excellent paper published this year, 2020, by Ken Mayer and colleagues, addressing in a narrative review addressing barriers to wider use of PrEP in the United States. And they focused on key barriers, and they propose potential approaches to removing these barriers. Some of the barriers addressed in this narrative review are universal, such as awareness of PrEP, or low HIV risk perceptions, or stigma. Some are more context specific, like the provider bias and the distrust of healthcare system, which are very setting specific, also within a given country, or access to medical care, because it depends on how medical funding and national health care services, whether they are available or not, how this is structured, this will very much influence how PrEP uptake and retention works in various settings. And of course, lack of access to financial assistance or fear to side effects are aspects that also need to be addressed. And because of issues, because of time constraints, I will not address the potential approaches to removing these barriers, but I suggest that you read this paper. I want to thank Timur Nuri, a colleague and friend from the European Centre for Disease Control, for providing me these very updated slides of 19th of November this year, which summarizes the status of formal PrEP implementation in Europe and how funding or reimbursement is available. You can see in blue countries where PrEP in Europe is not formally implemented, largely in Eastern Europe, and in various degrees of green countries where in the darkest green a PrEP is nationally available, and in the lighter green where generics are available, and this obviously facilitates PrEP uptake by various groups. And understanding how PrEP is reimbursed in various settings is definitely a key issue for understanding the PrEP gap. And this is another paper that I recommend that you also read, is the PrEP gap among men who have sex with men in Europe. And this is a paper by colleagues led by ECDC with other colleagues, that addresses the difference between the proportion of MSM participating in the IMI survey that responded that they were taking PrEP in green, with the proportion of MSM who responded would be very likely to use PrEP if it was available from them. And these proportions range from 45% in the PrEP gap in countries in the east part of Europe, where you could remember from the previous slide, PrEP was not available, to a lower proportion in the PrEP gap in countries where PrEP was available. These figures are 2017, so things hopefully have improved a lot for many of the countries where PrEP programs are being implemented. Overall, the PrEP gap in Europe was estimated to be of 17% in 2017, and I really think this PrEP gap has decreased, although as you can see there is substantial heterogeneity by countries that needs to be addressed. And which issues limit PrEP implementation in European countries? Well, the cost of the drug, limited technical capacity, and cost of service delivery were among the most important limiting factors. It is important to address the impact of the COVID pandemic in PrEP, and I have selected these two papers which I recommend to read, how in Australia up to 25% of PrEP users stopped daily PrEP, and 5% changed to on-demand PrEP, largely because they had stopped using casual sex during the lockdown, or whether they had decreased the number of casual partners. Finally, I want to thank ECDC for moving forward with this operational guidance on PrEP, which will be published in the first quarter of 2021, where they develop a minimum set of standards for PrEP service delivery in Europe, and they will focus on the case for PrEP as a policy brief, and they will also address country case studies that will help different European countries to implement PrEP in the various settings. So thank you to the colleagues within this important work. Finally, I want to stress the importance of building alliances that make sense in our setting. And to do this, I want to highlight how we worked with various health actors involved in health governance and decision-making in Spain, where we collectively incorporated PrEP to public funding a year ago. And this involved various sectors from the Ministry of Health, the National Committee on Public Health, the National Committee on Regional Coordinators, all NGOs, all various actors, and finally politicians. And I want to remind ourselves of this important proposition, not of law, supported by the Health Commission, the Spanish Parliament, supported by all political parties. Thank you very much.